So hi everyone, thank you for coming. We're the crash course series, and today is not actually maintaining life. I feel like I should have protected that. It's protecting life today. Anyway, taught by firstly Ganesh, who's one of the final year GEPs, and then I'll be talking after. I was a George's GEP and now I'm a F1 at George's. And then Ellie, who's one of the...
Yeah, I'm Ellie. I was a GEP at George's. I'm now working down in Exeter.
So we'll probably just get started now. So I'll hand over to Ganesh, who's going to go through hepatitis and meningitis.
Hi guys, well, welcome, good evening. Well done for making it here at such a late hour. Why is this not working now? Okay, fine. So we'll be going through hepatitis. So how we're going to do this is just have an overview of liver function, some of the clinical signs of liver injury, some of the liver function tests, how we can interpret them, and then we'll do an overview of like the common causes and viral serology of hepatitis. In particular, we'll be focused on hepatitis B, just because that's really what's examinable. That's predominantly what will be tested. All right, so just to start with, also, if you have any questions, feel free to kind of turn on your mic or just pop a question in the chat. Just an overview for the liver. So its functions, it's got energy metabolism, such as gluconeogenesis. Its synthetic function is making our clotting factors, producing CRP, albumin, which provides your kind of oncotic pressure within your blood vessels. It's also involved in storage of things like your AK and ED vitamins, so they're your fat soluble vitamins. It's involved in detoxification and clearance. So the medications we have, the liver has to make it hydrophilic, so it's water soluble, and then it can be excreted in stools and urine. So when we're kind of assessing if the liver's functioning well, despite it doing a range of things, what we actually focus on is what I've got in bold, synthetic function. The reason for this is when there's liver injury, the liver has actually got a lot of kind of reserve, if you will, so it can still continue doing energy metabolism, still kind of detoxifying medications and things like that. So, however, synthetic function is a bit more sensitive and it's less resilient. So if there is a liver problem, the synthetic function will kind of go off before any of the others. So things we particularly look at is albumin and clotting factors. Yeah. So hepatitis just simply means inflammation of the liver. It doesn't have to be infective. It can be infective, such as hepatitis B, C, or non-infective. So really common non-alcoholic fatty liver disease, alcoholic fatty liver disease, or even an acute reaction with a certain medication. Worldwide, the most common is viral hepatitis, B's and C's, partly due to vaccination and things, and kind of protective measures. I think in the United States, the most common is, I think it's alcoholic fatty liver disease, and in the UK, viral hepatitis C is the most common infective cause. So yeah, that's kind of overview of causes. Okay, so have a think about this based on what we've talked about here. So signs and symptoms of liver function when it's deranged. So they can be completely asymptomatic. Like I said, the liver has a good amount of reserve, even with some injury. So they can appear totally asymptomatic. And they can have these flu-like symptoms, so fever, muscle pain, fatigue, much like having the fever. And we call this the prodromal phase. So somebody may present with, possibly a bit of jaundice, which is like yellowing of the skin or something. And when you inquire the history, they may say, a week or two prior to that, they felt like they had a heavy fever, just tiredness. Yeah. So specific things, one that kind of really signifies liver damage and things that are quite examinable. So jaundice, which is yellowing of the skin. You can get bruising because the liver's ability to produce clotting factors and things has been reduced, so you bruise more easily. Right upper quadrant pain due to inflammation of the liver. And you can also get hepatomegaly, which is just an increase in size of the liver. So I think if you've done your abdo exams, you're meant to check for hepatomegaly, splenomegaly. So it may be kind of placed in a question where, the liver, the tip of the liver edge is palpable 3 or 4 centimeters below the ribs. That's kind of referring to hepatomegaly. Right. So that's the signs and symptoms. But in terms of reviewing liver function based on tests, so it might be called a liver panel or liver function test. There's a few more, but four I'd like you to focus on and really get to grips with. So ALT, I think it's called alanine transaminase, but I think of this as a liver test. The reason is this is the most specific marker for liver damage. So the comparison that you can draw is what troponin is to cardiac tissue, ALT is to liver tissue. Yeah, so it's found in really high concentrations, and when there's any kind of damage to hepatocytes, this gets released into the bloodstream. AST, I don't actually remember what it's called, but I think of it as a systemic test. And the reason is it's not exclusively found in the liver. A lot of it is, but it's also found in heart tissue, muscle, and some blood cells. So it tends to rise with ALT, and also it can rise quite high when you get into end-stage liver disease, when there's quite kind of liver cirrhosis and things like that. So these two markers are very, very sensitive for kind of liver damage. You also get Aop and Ggt. Now these are found in your bile duct, which is, unfortunately I haven't got a picture of this, but it's just below the liver. ALP is, I think, alkaline phosphatase. That's concentrated a little bit in the liver because if you remember, so you get your two hepatic ducts, which form the common bile duct. So as part of it is in the liver, you get a bit of ALP there as well. ALP is also found in bones. So a rise in ALP could indicate either is there a bile duct issue or something with bones. So it's usually when there's increased bone turnover. So such as, in certain bone cancers, you might get a raised ALP. So it leaves you with a slight problem because if the ALP is raised, you need to identify, is this a biliary duct problem or is this a bone problem? And that's where GGT comes into place. GGT is almost exclusively found in the liver and bile ducts. And it's usually like the first enzyme to actually start to raise in kind of any bile duct obstruction. So if you found ALP raised and the GGT level is completely normal, this would make you think, okay, this is actually more of a bone issue. This is not as a result of a kind of liver or biliary duct pathology. So when you see a raised ALP, assess the GGT. Yeah. So yeah, that's the four. There's a few more you can use, INR, bilirubin as well. The thing with bilirubin is, so you'll find that people's, so there's conjugated and unconjugated. But I think for your level, you just need to know like a high level of bilirubin would indicate either, you've got a lot of blood cells being broken down before the liver, or there's a liver problem. So it's pre-hepatic causes, hepatic and post-hepatic causes of jaundice. So just have a little read around that. But bilirubin is also something that's used. Again, if say ALT, AST, all these markers were completely normal, and this person had jaundice and the bilirubin is highly raised, you wouldn't think there's a liver issue. You may think, okay, they've got lots of hemolysis, so this is a prehepatic problem. So it's kind of how you use them together to actually form a kind of idea of what could be going on. But it would be well worth having a little read of that as well. So we're coming to the types of viral hepatitis. Now, so I know if you're anything like me, when I saw this kind of table, I'm like, whoa, this is information overload. So I'm going to filter it down into the most succinct things that I think you need to know, and from like year one, kind of going back on how the questions were kind of based. So, firstly, hepatitis A and E, okay, they only have an acute impact on the liver. They don't form into a chronic picture. And the way you can remember this is A and E are in the word acute. You can also think about A and E, the department A and E is for acute problems. So that's one thing. The other thing you need to know is, so you get B, C, and D. Hepatitis D cannot exist without someone being infected by hepatitis B. And I think it's to do with, I've got it here. So the coating of the hepatitis B virus, that's what actually allows hepatitis D to enter their host, because hepatitis D is actually a partly defective virus. So somebody that has hepatitis B can be infected, but without it, you're unable to get hepatitis D. And then that leaves us with hepatitis C, which there's no vaccination for. So there is a vaccination for hepatitis A, and there is one for B. So if you have someone that's got complete vaccination up to date, then you can think, okay, so they're protected against hepatitis A, and they're protected against hepatitis B. And by being protected by hepatitis B, you're therefore protected against hepatitis D. You're then having to decipher between C and E. And then we can look at the kind of transmissions. So again, A and E are both acute, and they're both usually contracted through contaminated water, so fecal oral route. So places with poor sanitation, that some of the sewage water or something can leak out into drinking water. That's how you may contract hepatitis A and E. Hepatitis B, they have the 3 Bs. So you can get through parental transmission, so needle, stick, or blood, through sex, and it can be transmitted to a child during birth. And that's usually because I think it's when the child is actually passing through the vaginal canal, there's usually some blood transfer. So leaving now hepatitis C. So hepatitis C is actually the most common reason is parental transmission. So that's needle sticks, blood transfusion, those kind of things. It's very rarely through sex or childbirth. So to put it into context, say for example you have an IV drug user they're fully vaccinated, they have their vaccines, and they're IV drug user, and they present with hepatitis, hepatic signs, so maybe some jaundice or the kind of prodrome of flu, myalgia. It helps you, they're fully vaccinated, so you think it's less likely to be hepatitis A and B and D. IV drug user, that's their main risk. They live in the UK. Generally, everyone has access to clean water, so you can narrow it down just based on that. It's quite likely to be hepatitis C. Other things, yeah, I think that's mostly it. The other thing you need to think about is hepatitis E. It's quite dangerous in pregnancy. So although it's acute and you're not left with chronic changes, in pregnancy it's very dangerous. It's about 30% of pregnant people, pregnant women that have hepatitis E will get something called fulfillment hepatitis, which is quite a severe end of hepatitis. So that's the only time you really need to worry about those kind of things. In regards to B and C, B doesn't really develop into a chronic picture. Your risk of it becoming chronic increases with the earlier age that the person gets it. So, if a 7-year-old child were to contract hepatitis B, they would have a far greater risk of developing chronic than, say, a 27-year-old that had hepatitis B. In regards to hepatitis C, if they're infected and it's untreated, and I think it's more than 20 years, there's almost an 85% chance they will develop a chronic liver disease. So hepatitis C, and remember, a lot of people can be asymptomatic for many years until it kind of develops chronic features. So a lot of people can go on to develop chronic changes in the liver, but it's predominantly hepatitis C. You can think it's chronic if you need to. That's the one you really want to worry about. Okay, so we have some questions. Let me see if I've got any other interesting facts. Yeah, no. Okay, so I'll give you all a few seconds just to read this. Okay.
See the chat, Ganesh, or no?
No, I can't see the chat.
No. If people want to write their answers in the chat, I can read them out.
Yeah.
Keep people more awake if they type. So we've got 2 C's, 3 C's, 4 C's, lots of C's.
This is why you guys are the JEPs. Okay, good. Yeah, so hepatitis A and E, and typically fecal oral route. Next.
So we're getting so far lots of A's. Yeah, more A's coming in.
All right, good. And just a note on this, a common thing, I think a lot of hospitals, because you'd be immunosuppressed, they often get tested for HIV as well. I think 1, because the route of transmission is quite similar, and 2, I think when you're immunosuppressed, it's another thing. I think at George's they might do it as well. That's more for your clinical knowledge. It won't come up in an exam. Okay.
So far we've got a mix of D and E. Slightly more D's actually.
Okay. So yes, I can see why you would put hepatitis C. There's no vaccine, and left untreated, it can become chronic. But if you remember, I think it's about 30% of those that have hepatitis E in pregnancy can develop fulfillment hepatitis, which is basically a very acute liver failure. So it actually carries quite a high kind of mortality rate, both for mother and child. So that's why hepatitis E is very dangerous in pregnancy. So something you just need to think about. Hepatitis C, I can understand why, but because of the rapid transformation into fulfillment hepatitis, it's a lot more dangerous. All right, so viral serology, and I think when I was fresh, I really did not like it, but it can be broken down into a very simple way now. So let's see, remember I got, yeah, so put simply, you've got 3 antigens and 3 sort of antibodies. Now, if you look at the surface antigen, if that's showing as positive, there's only one reason: this person is infected. At that moment in time, they have an infection. So that's something you've identified. Okay. So next thing you look at is possibly the surface antibody. So that can be positive for 2 reasons. Either they've launched a successful immune response against the virus, or the second reason could be they've had a vaccination. And the way to differentiate between this person has had an infection or they've been vaccinated is, if they've had an infection, they'll have surface antibody positive and they'll have a core antibody as well. If someone's been vaccinated against hepatitis B, they are only surface antibody positive. They will not have a core antibody positive. So then if we're sticking to the individual that has been infected with hepatitis B, so they're surface antigen positive, they have a surface antibody positive, and they're core antibody positive, you can then break it down into, is this acute infection or is this chronic? Because you can carry it. So I think up until 6 months, it's classed as an acute infection, and over 6 months, it's chronic. So you check the IgM, and if the IgM levels are high, this will be an acute picture. If the IgG levels were high, this will point more for a chronic picture. There's also, I think, so you get this E antigen as well. So the reason this is important is you might have someone with, say, a chronic picture. Yeah, someone that's basically had a chronic picture, and you think, okay, they've got a surface antibody, they've been vaccinated, they've got this infection. The E antigen, it tells you about the level of E antigen tells you the viral load of this individual. So if the viral load is very, very high in the E antigen, you think this person is actually very, very infectious. Whereas if the E antigen is extremely low, you think, yes, this person has the virus, but the viral load is so low that the chance of transmittability is quite low. So it's the same for any kind of virus, whether it be kind of COVID or anything. You kind of assess the viral load with it as well. So thinking about this is, you would check for surface antigen. If it's positive, they're infected. You can check then for core antibodies. And if it's IgM, you think it's an acute infection. If it's IgG, it's a chronic infection. You can then check for your surface antibodies. So if it's positive, it's signs that you've either beaten or launched a successful immune attack. The reason you'd sign of, if you contract hepatitis B, you're not going to see a surface antibody for the first few weeks. So, if someone's positive for surface antigen, the IgM is raised, but there's no surface antibodies, you may think, okay, this is very acute, maybe in the first 2 or 3 weeks. And that's why we're not seeing the surface antibody. And then, as we spoke about, the HBE, the envelope antigen, that's telling you the viral load. So if it's high, they're very highly infectious. If it's low infectivity. Right. Okay. So this probably won't work in the chat of this, but just think about it in your head as well. So a susceptible individual, if I told you this is someone that has no protection against hepatitis B, so they haven't been vaccinated or anything, they have no protection, what would that look like? So will they have a surface antigen? They won't, because they haven't been infected previously. They won't have the antibody for the surface because they haven't been infected, nor have they been vaccinated. If they haven't been infected previously, they won't have the core, the HBC, the anti-HBC, they won't have that. So what I want you to do is, I don't know if you could take a screenshot, you can probably find this table somewhere, but just, cover it up, think about, okay, if they're vaccinated, then they should have the anti-HBs. They will be negative for the HBs antigen, and they won't have the core because if you're vaccinated, you just get the surface antibody, you don't get the core. And just kind of go through it like that, yeah? So if we look at, acute infection, chronic, IgM and acute, IgG and chronic, and this is sort of, a very typical question they'll give you in the exam. I think I might have actually created some for you. Yes, I have, yeah. Okay, so social.
Oh, we're having yeah, loads of people have put B.
Good. Okay, good.
So maybe C's or A's.
This is quite. Okay, so this is quite kind of typical of the type of question you may get. If anyone's unsure about anything, please feel free to kind of put in the chat, just ask.
I think we only had 2 people answer the last one, so I think they just need a bit more time, probably.
Oh, sorry. Yeah, if you could just let me know when it's a good time
this one, we've had 2 people, 3 people? I can't remember if that was from last. Most people saying A so far, but I think give it a few more because we've only had 2 or 3 people answer. Yeah, we've got another A. Another A. Yeah, everyone seems to be going A.
Okay.
Yeah, I haven't had any more through yet.
Okay. So I'll just kind of run through this. So the first point, we have the hepatitis kind of antigen is negative. So if the surface antigen is negative, this person hasn't got an infection. They have not got an infection. The next part is the hep surface antibody is positive. So you think, okay, it can be positive because they've previously had an infection and they have immunity, or they've been vaccinated. So if you've previously had the infection, you will have surface antibody positive and the core antibody positive if you've had the infection. If you're vaccinated, you only have surface antibody positive, you won't get the core antibody. So when we look at this, we see the core antibody is negative. So we think, well, they can't have had the infection in that case. The surface antibody is positive. So you think, yes, they're vaccinated. You can be vaccinated and still possibly have an infection, but the surface antigen is negative. So they do not have an infection at that moment in time. Yeah? So that's how you can work through it.
So we've got so far everyone has said A. Maybe give it a few more seconds. Yeah, another A. Yeah, it doesn't look like there's any more coming in. So everyone said A.
Fantastic. Yeah, great. So they've got the surface antigen is positive. We know they're infected. We look at the surface antibodies negative. So we can think, okay, either they haven't been vaccinated, or they haven't had an infection previously. But the core antibody is positive IgM, meaning acute. And we said earlier that it takes maybe 3 to 4 weeks or a little bit longer for the surface antibody to actually be produced, saying either the infection is resolved or a successful immune response being launched. So well done, good. All right, yeah. So that was your kind of whirlwind tour of hepatitis, Lfts, and some of the clinical pictures of someone that would present with kind of hepatic involvement. Any questions?
I can't see any more questions in the chat so far.
Okay, great. Do you want to just switch into the next presentation, or do they need a few minutes? Or
there's like a half question in the chat. I'm not sure if they're still typing.
Maybe get started, and then if any pop up, we'll let you know. Oh no, there is one. Would there ever be a positive antibody test but a negative surface antigen test? The positive antibody.
Yeah, so you can get a positive core antibody with IgM, but you might not get the surface antibody because the core antibody will be produced first in the first few days to weeks, whereas your surface antibody will only come about after a few weeks, or once the infection is resolved almost. So that's the time you can see it. Yeah, and that's why if you think, okay, they've got a surface antigen, they're infected, and you look at the core antibody and the IgM levels are high, you think this is quite acute, this is within a few weeks, and that's why there's an absence of the surface antibody. No worries, no worries. Okay, let's just get your next slides up. Okay. Sorry, I'm not quite sure what happened there. Okay. Okay. Can everyone see that?
Yeah, we can see it.
Okay. Okay, so for our next topic, we'll be going through meningitis. Yeah, meningitis. So again, like hepatitis, it just means inflammation of the meninges. Yeah? So it can be due to an infectious cause and non-infective causes. So we'll have an overview of what meningitis is, different causes, signs and symptoms, and the investigations. I'll try and kind of build a picture of what your patient with meningitis is sort of like. So how I think it's very useful actually to think about this. So you need to know, the layers. So the pia mater. So I'll explain like this. If you imagine the brain being wrapped with cling films, it's really tightly adhered to the brain. That would be your pia mater. Then above the pia mater, you get a space, which we call the subarachnoid space. And then you get your arachnoid and dura mater. but the arachnoid and dura mater are really, really closely bound onto each other. And I mean really tightly bound onto each other. And then your dura mater is what's kind of adhered to the skull. The dura mater is actually kind of, I think it's got a greater adhesion to the arachnoid mater than it does to the skull. And the relevance of that will kind of bring into later, because when we look at CT head images about whether it's an extradural bleed or subdural bleed, that really kind of helps guide you. But just if you think about it like that, it really does help with kind of interpreting CT images and things like that. But essentially, that's what you need to know. So, you know, your pia mater, then subarachnoid space, arachnoid, dura mater, your skull. Okay. Oh, and in case you didn't know, pia, dura, and arachnoid, these are the meningeal layers, and they run in the brain and they run down the spinal cord. So, like I said, inflammation of the meningeal layers, it doesn't pertain to just infective causes. Yeah, it can also be non-infective causes such as bleeds. So in blood, particularly I think the iron within red blood cells, they're very irritant to the meningeal layers. So things like subarachnoid bleed or any kind of bleed in the brain, it can cause inflammation of the meninges. So looking at the kind of infective causes, so bacterial Neisseria meningitis and Streptococcus pneumonia in the bacterial are overwhelmingly the most common bacterial causes. And in viral causes, enteroviruses, such as Coxsackie echovirus, they're the most common, followed by herpes simplex virus. And I think typically it's HSV2, and that's kind of found in meningitis. It's not exclusively, but more common than none. And if, you know, enteroviruses, when I first heard it, I wasn't really sure what it meant. It simply means things that are an infection that's acquired through the gut. So, you know, you have to kind of consume. So it's usually, you know, respiratory droplets or nasal droplets taken in orally, going through the gut, and that's how you acquire these viruses. Another thing we'll come to, but you know, Neisseria meningitis is a gram-negative bacteria. Streptococcus pneumonia is gram-positive. Obviously, your viruses, they need PCR to be identified. And it will come into relevance in a little while. So, yeah, this is just an overview of like your age ranges, things like that. As you can see, like Neisseria meningitis and Streptococcus pneumonia cover most of the age ranges actually. Now, I think it's almost, I think, so Neisseria meningitis, it's about 11% of people have it in their nasal passages, completely asymptomatic, doesn't cause any harm. And again, Streptococcus pneumonia, I think it's similar where, yeah, it's about 40% of children have it colonized, Streptococcus pneumonia, and about 10% of adults have it colonized. Again, asymptomatic carrying. But you can imagine if people are carrying around asymptomatically, it's a lot easier for it to start to penetrate into the blood-brain barrier. So in children, yeah, I think group B Streptococcus, some of the gram-negative bacilli are more common. But I think overall Neisseria and Streptococcus is what you're tested on most in exams. And it's got the gram-negative, gram-positive things that help differentiate it. I mean, this isn't something that will come up in exam, but children up until the age of 5 or 6 months, they don't actually develop the blood-brain barrier to protect them from some of the infections. So that's why often, you know, if you think a child, you know, a lot of adults carry around asymptomatically. If it's spread into a child, you know, under the age of 6 months, there's no blood-brain barrier that's properly being formed. So meningitis is quite common in the very young children, and we get very, very worried about it. Similarly, in the kind of older age population, you can be kind of immunosuppressed, so your immune system just isn't functioning as well as it was in earlier years, and you could be a bit more susceptible to these infections. So there are a few symptoms that are associated with meningitis. Now, I think something like, depending on the studies you read, about 50 to 70% will report fever, headaches a little less. I think it was like 46% to almost 74% will report headache as individual symptoms. So what they've come with is the triad. By combining these three symptoms, you might get a more sensitive kind of diagnosis. So fever, if they have an infection, fever, headache, the meninges are swollen in the brain, it will cause pain, and neck stiffness. The neck stiffness is simply because the meninges are running, all around your brain and down your spinal cord. So for me to be bending my neck, I'm actually stretching the meninges. And it's a bit like if you've gone and bumped your arm or your leg and it's inflamed. It doesn't particularly want to be moved or stretched. It's the same with the meninges. When they're inflamed, they do not want to be stretched in a movement, and that's why you get this neck stiffness. So an adult, anyone that can kind of verbalize can say, yeah, it's uncomfortable to move my neck. But in a baby, and again, these are your kind of at-risk population, they won't be able to verbalize these things. So something we have to notice, is the baby kind of wriggling around, but it's not moving their neck or head as you would expect. So it's a kind of sensitive sign in those cases. And photophobia, which is a dislike for bright lights, another really, really top thing they will put in exams. It's another kind of really key thing. If a patient presents with that, there's something kind of quite serious going on, and you have to have a kind of high degree of caution with those patients. So headache, fever, we discussed. Now this thing about the confusion, altered mental status and things, and again, it's greater than 70% can present an altered mental status. If someone is particularly older, a child that's nonverbal or something, they might not be able to tell you exactly what symptoms. So someone has confusion, that's altered mental status. If if a baby seems very quiet, tired, hard to arouse, that again can be classed as altered mental status. So those are the kind of, the question may not say a patient comes in altered mental status. It may say, a 6-month-old child seems quieter than usual, has a fever, and grimaces in bright light or something like that. So that's saying photophobia, fever with some altered mental status. So that triad is really important, but there are more subtle things as well, just to be aware of. Now, okay, so I'm not sure if you all remember this. There was an ad many years ago. It was one of the NHS campaigns, I imagine. It was a glass tumbler being placed against skin, and there was a rash. And this was because meningitis, even still now to some degree, it was being missed a lot. So there's a public health campaign almost to kind of say the glass tumbler test. And if the rash did not disappear under the glass tumbler, this is a non-blanching rash, this is emergency, go straight to a hospital or something. And the thing with the rash is it's a very, very late sign of meningitis. And actually it's called Meningitis Septemia. So now we've got, liver functions being impaired, you've got a disseminated anticoagulation. The bacteria of meningitis actually spread out into the blood, and they're releasing toxins, and that's another reason you get a rash. So it's a really late sign. That's not the sign that we want to be looking out for meningitis. We want to identify it from the fever, the altered mental status, the confusion, neck stiffness. When we get to a rash, we're really against the clock. But that's, if it comes up in the questions, it's meningococcal septicemia. It's a very late sign. Photophobia again is another nice sign, and again, it's something, you know, if somebody comes in with a fever and headache, which you think, you know, that could be the flu, they might not have neck stiffness, but photophobia, you don't get that with the flu. You don't get that with many infections and problems that disturb brain function. Photophobia is present, so it's a really good thing to look out for. Okay, so these are your classical signs. I think, yeah, these are definitely something that can come up. So kerning sign and Brzezinski sign. So kerning sign is about the knee. So K for K. And what, you know, I've got pictures. Yeah, this is that. So what will happen? Remember we said the meninges run from the brain down the spinal cord, right? So it's nice and kind of taut. So what happens when you're bending someone's hip and trying to straighten their knee? You're actually putting tension along the meninges. You're stretching the meninges. And because it's inflamed, the person will do something to compensate for this. And what they'll do actually is they'll report pain, but they might also try and lift up their neck. And that takes the meninges from a kind of taut and slack position to kind of giving it some bend to reduce the pain. So that's the kerning sign. So you lift up their hip to 90 degrees and you try and straighten the leg. If that elicits pain, it's, you know, along with fever, headache, it's quite sensitive for meningitis. Another one you can do is Brzezinski's, which is bending the neck. So your patient's nice and flat, and you think, you know, if it's an elderly patient or you know, maybe someone that's kind of hard to get the hip up and do those things, have a patient that's nice and flat. You just try and bend their neck up, and in response they may flex their knees. Again, this is a compensatory response to reduce some of the tension going through the meninges, and that again is another sign that kind of leans you towards this meningitis-like picture. So yeah, that's two things. There's also another one where it's torsional head turning. So you'd get them to twist their head 2 or 3 times, and that's got a high degree of sensitivity. But I haven't seen that in any of the exams, any of the past med questions. I think that's a bit of a research kind of topic at the moment, but it's something you can read up on if you want. Investigations. So before we get into this, okay, let's see. Yeah, we're going to talk about lumbar puncture quickly. So we suspect meningitis. We suspect there to be an infection within the kind of cerebral spinal fluid that's affected the meninges. So the way we can test this is by doing a lumbar puncture. Now, you can do this between L2 to L5. Typically, they try and just do it between L3, L4, or L4, L5. To get to L4, or you know, around that is, you take your anatomy. So you want to go to the ischial spines of the So if your hips, you go to ischial spines. And if you palpate both, you need to think about an imaginary horizontal line across them. And when you think of that horizontal line, you follow along with your fingers, and you can either go below or above. So when you feel that gap, you know you can either be in between L3 and L4, or between L4 and L5. The reason you want to be there is no spinal cord present. You get these kind of tails of the spinal cord, but not the actual cord itself. So when the needle goes through, it typically just pushes some of these tails apart. It won't actually puncture the spinal cord or anything. So that's why that's the safe space for you to enter. So you take a sample of this fluid and you're going to be testing to see if it's bacterial or viral. Now, coming back to this, so that's lumbar puncture. Blood cultures, because you know there's two things with blood cultures. One, they try and grow the bacteria in various different plates, and if they are able to grow it, they're also able to put the medications, such as types of penicillin, and they can find out, oh, this bacteria is actually quite sensitive to a particular antibiotic per se, or something like that. So that's why they do blood cultures. Actually, so they might do a PCR as well if it's viral. You do a full blood count. So you check for white blood cell count, CRP, but you'd also do blood glucose. I don't expect you to know why, but the reason is you need to get a diagnosis of bacterial viral meningitis from your lumbar puncture. You need to compare the glucose level in the CSF with the glucose level that's in serum. So, I've seen it where, unfortunately, you think about a lumbar puncture, someone does a lumbar puncture, sends it off to a lab, lab will immediately phone and say, we don't have a serum glucose to match this. Can you go and get one? Because it's almost, vital to interpret the CSF readings. I've got Lfts. It's not lateral flow test. It's your liver function test. The reason is basically you need to make sure this person's clotting is within normal range before you lumbar puncture. Because with lumbar puncture, there is a risk of causing a small bleed or a bit more of a traumatic bleed. If their clotting is severely deranged, you're now introducing a lot of blood into the CSF. And that in itself can cause meningitis and various other complications. So you need to make sure the clotting is within a normal parameter before thinking about lumbar puncture. You do a neuro exam. I think the neuro exam is less important, but if for example, you're thinking it could be meningitis, but there's not a lot of things that fit, you can do a neuro exam, check for photophobia, maybe do some cranial nerve things, and that can help you. But the definitive thing here is really the lumbar puncture test. So we spoke about how we do the lumbar puncture, extracting the fluid. I think you take 3 samples, but you don't have to worry about that. Essentially, you go into the subarachnoid space. So you go through the dura mater, you go through the arachnoid mater, and you get into subarachnoid space. Okay, so I know I have fungal and TB here, but don't worry about that. That's not what you're expected to know. I think even in final year, we're not expected to know this either. But bacterial and viral, very much so. The nice thing about this is they're really easy to differentiate. Well, on paper at least. Bacteria have a much higher cell count. Bacteria use a lot more glucose than viral, partly because of the increased cell count. And because of the increased cell count, I think the protein level is typically a lot higher as well. So bacteria, your cell count, white blood cell count, is very high. Your glucose levels are low, so typically below 60% of the serum, and that's why we need the serum glucose. And your protein levels are very high. In comparison, viral, it's almost the opposite. The white blood cell count is quite low, it's below 200. You get a normal glucose level, and the protein levels are generally near normal. Yeah, that's the main ways to differentiate them. Anything else? Okay, so I'm trying to look for some interesting facts, but I think we can jump into some questions actually. Yeah, so just remember the meningitis can be caused by infectious and non-infectious causes.
So we've got a couple of B's so far, but only a few people have replied. Everyone so far is saying B. Oh, a couple of A's.
Okay. So it's a slightly mean question.
1 C.
Slightly mean question, but I'm pretty sure this is something of this type of wording came up in first year exams. Let's see. So it's the subarachnoid hemorrhage. So it's a kind of bleed in the subarachnoid space. And remember, blood is an irritant on the meninges as well. Now, what we need to look at here is it's a sudden severe headache. In bacterial viral meningitis, so they'll have a time frame of days. I think viral might be 2 to 4 days, and bacterial being 3 to 7 days. It kind of builds up gradually. It won't just come on all of a sudden. So this has happened all of a sudden. Severe headache and photophobia and vomiting. So the headache, photophobia and vomiting, they could be either infectious or non-infectious, but it's this sudden onset. And this is really making you think, hold on, there's signs of meningism, but these signs came on suddenly. Cause of meningism could be infectious, also non-infectious. You can rupture a blood vessel in the brain like that, and that will present very quickly. Whereas your bacterial viral symptoms, they're going to be building up for days. Yeah. So this is what this test, this question is going to test: sudden severe headache. Think about your subarachnoid hemorrhage. There's classic things of a thunderclap headache, the worst headache they've experienced in their life. Some people actually, they kind of lose consciousness almost because it's an abrupt change in pressure in the brain. Okay, and yeah, so migraines, you can also get people that have like severe migraines that also report photophobia and vomiting. But let's put it in the chat, what symptom that's typical of meningitis will be absent in a migraine? So remember, migraine, they can present with photophobia, vomiting, and headache. What won't migraine have that meningitis will have, or more than likely will have?
So we've got lots of people saying neck stiffness.
Yes, you sort of can get that as well with meningitis.
Then we've got non-blanching rash.
Okay, yeah.
They'll not be able to touch their chin to their chest.
Okay, think a little bit simpler. So a bedside test here. So what was our triad for meningitis? Think about the triad of meningitis and then think which of these can't be present in migraine.
Someone has said fever.
Perfect.
Yeah, 2 people have said fever now.
Because what you have is a question where it's very hard to distinguish this person has photophobia, they're vomiting, severe headache, but the temperature is 38.1 or 38.4, something like that. So just keep an eye out for that, because migraine can really at times overlap some of the symptoms. And the subarachnoid hemorrhage, the only difference is it's a very, very sudden onset.
So we've got a couple of answers starting to come in. Most people so far are saying A.
Okay, so this question is a little bit unfair because I think actually bacterial meningitis probably in the 19-year-old college student is probably quite common, and that's why you get the meningitis. I think it's YZ as a vaccination. But the thing I want to draw here is recently had a bad chest infection, and I think you may recall that we said up to about 10% of adults will carry streptococcus pneumonia asymptomatically in the nasal passages and some of the respiratory tract. So I think I've actually put bacterial meningitis, but I'm thinking more of the streptococcus pneumonia as opposed to say Neisseria meningitidis. But again, it's something you would probably do a gram strain on. And again, it's something, if the question says they're a fully vaccinated 9-year-old student comes in and they've had a bad chest infection, okay, you would probably lean towards Streptococcus even more so. Okay. So, yeah, so if this was our student and you've correctly said yes, I think it's bacterial meningitis, you then get a gram stain for the CS. No, yeah, you get a gram stain for the bacteria. What would you think?
We've got someone saying B. Another B. More B's coming in.
Okay, good. Yeah, so Neisseria meningitis. No, okay, wait, that's wrong. It's Neisseria meningitis. Sorry, I think I've highlighted the wrong thing. Streptococcal pneumonia is a gram positive. And Neisseria meningitis is your gram negative. So yeah, sorry, whoever's placed B, that's correct. HSV is herpes simplex virus. It's a virus, can't be gram stained, has to be PCR'd.
So we've got a couple of people so far who've said A. Oh, they've got a D. And then another A.
Okay, so I'm just gonna go. Right, so yeah, it's bacterial meningitis, and like I said, it's low glucose. The protein count's usually high, and the white blood cell count is often very high. So that's all indicative of bacterial meningitis. TB and fungal, again, you don't need to know it at this stage, and I don't think I've had to know it through any of the years so far. I think it's just something that's a lot less common, especially in the UK. Probably why we don't need to focus on it as much. But yeah, I certainly haven't come across it in any of the exams or I think even in the question banks and things.
Someone's asked, could you quickly clarify what PMN is?
So it's polymorphic neutrophils. So if you remember, you get your neutrophils are like your granulocytes, basocytes, poly meaning a lot, morphic meaning different shapes. So you get your granulocytes, basocytes, and things, and that's again more indicative of a bacteria. So there's lots of them. There's different shapes to them, and that's kind of what you see in the bacterial meningitis. That makes sense.
Yeah, they've said thank you.
Okay. Yeah, so just to come back on earlier what I was saying about the whole cling film is your pia mater that's wrapped around the brain, and how your dura mater and arachnoid mater are very, very closely kind of adhered onto one another. So epidural, meaning above the dura mater. So as I said, the dura mater and the brain, the dura mater is adhered onto the brain. It's not as tight as the arachnoid mater. So when you get a bleed above the dura mater, it can actually start to peel some of the dura mater away from the skull, and we start to see these bulging in. Now, in contrast, when you get a subdural bleed, so beneath the dura mater, but you remember the dura mater and the arachnoid mater are very, very tightly adhered, you don't get this whole pulling away of the arachnoid matter as easily. what you do get is obviously there's some space between these two layers. They're not one, there is some space. And what the blood does is typically fills in that space and kind of treks along it. There is a bit of a separation, but it's nothing where in the epidural where it's a clear kind of breaking away from the kind of skull base. So when you see this kind of bulging, you think, okay, something's actually coming away from the skull base. That's the dura mater, and it's epidural. Because if it's subdural, those two layers are bound really, really tight. They don't just break away. And what tends to happen is the fluid kind of builds up and just runs its course around the shape of them. Yeah. So yeah, I think, you know, I remember first year and somebody said to me, you know, it's the banana shape is the subdural and the lemon shape is the epidural. And yeah, you could probably answer a few questions, but it's not very helpful. I don't think it's very helpful. Whereas, you know, if you learn it from now, how these layers are actually formed, you know it for life, you can understand the pathology a lot better. So yeah, that's your subdural epidural. I just wanted to put that in there because it's always coming up in exams. It's super, super important. It's just something I am hoping you can just take away and know for life now. Yeah, I think. Okay, yeah. Well, does anyone have any questions? Feel free to put in the chat.
There's a question here. So the question is it also lemon shaped because of the fascia or more adherent to the sutures of the skull, so the bleed can't pass those joints easily?
1 second, let's go back. So the epidural, so the reason it's partly that shape is because the dura mater can come away from the actual the lining of the inner skull, and there are suture lines, and that might be why, you know, you get the bulge and you don't get the full around the whole side of the brain. Why it's kind of limited into, if you look at the actual bulge, there's two distinct places, and then it comes to concave in. It might be to do with suture lines, but it's also to do with the adherence between that and the skull base. There's a bit more give, and that's why it can actually bulge out. Whereas the subdural, they also have suture lines. However, the adherence between those two layers is so much so that the blood just kind of runs the shape between them, as opposed to kind of sharing them off one another. Does that help?
So I'm Anaya. I'm going to be going through multiple myeloma. So we're going to start off with a question. So multiple myeloma is a hematological malignancy affecting which type of cell? So T helper cells, immature B cells, plasma cells, natural killer cells, or the lymphoid progenitor cells?
Got a couple of C's coming through.
Cool.
Just give it a couple.
Yeah, tell me when the answers slow down.
Yeah. No one else has put anything in that.
Cool.
Oh, there's another C.
It is C. So, all right. So just a quick overview of myeloma. So myeloma is a malignant disorder of plasma cells, which are the mature B lymphocytes. It's actually the second most common hematological malignancy. So it's actually really important that we all know a bit about it. It's characterized by excess production of a monoclonal antibody, and we'll go through what that is through the talk. And it accounts for 2% of cancer-related deaths. So just reiterating again, it's actually a really important condition to know about. So the first thing you need to know when you're thinking about hematological malignancies is just know a little bit about hematopoiesis. And this always used to kind of confuse me, knowing which ones were myeloid and which were lymphoid, until I just thought about it that lymphoid, all you need to remember is it's the B, T and the natural killer cells. So everything else is on the myeloid side. So that's my way of remembering it. Just if you're stuck, it's probably myeloid. For multiple myeloma, it's an issue with, like we say, the plasma cells. And the part that I've highlighted is kind of the pathway that goes wrong.
Oh, somebody's just asking whether you could repeat that last bit.
The bit about which go where, or? It's basically, I just put this in really just to highlight. You don't need to kind of memorize the whole thing, but I think.
Oh, he says about how you remember them.
Ah, okay. I basically just remember that pretty much everything is on the myeloid side, apart from your B lymphocytes, T lymphocytes, and your natural killer cells, which we don't really actually talk about that much. So basically just separate it that most of it is myeloid apart from those 2/3. And then you need to know a little bit about antibodies. So the structure of antibodies is that you have this heavy chain, and then at the top you have your light chain. Your light chains are always either kappa or lambda, so it's quite simple, they're one of those two. And your heavy chains can be one of 5, so it can be alpha, gamma, delta, mu, or epsilon. And your heavy chain is what determines what kind of IG it is. So if it's IgM, it's because that heavy chain is a mu chain. If it's IgE, it's because it's an epsilon chain. And the bit at the bottom always stays the same, and the bit at the top is your variable region. So that's the bit that kind of changes slightly and allows the antibodies to kind of attach to different antigens. Another question, which class of antibody is able to cross the placenta?
Got a D, got a couple of Ds coming through. Just wait a little bit more. So got mostly Ds, got a C here as well.
Cool. Yeah, so the answer is D. So I like to remember this one. This is just one that occasionally they like to test, but it's really easy to remember once you think that it's got a little g and then a big G. So it's like a little baby G and then a big G, and then you can remember about it being the placenta one. They don't really quiz you, from what I remember, correct me if I'm wrong, other people, but don't quiz you too much on the different immunoglobulins, but this is one of the ones, the questions that does tend to come up sometimes. So just going through the different antibodies. So IgG has that gamma chain, exists as a monomer, lots of it in serum. It's kind of produced later in the immune response. IgM is the antibody that kind of appears first in infection. They sometimes do ask you about kind of the different structures. So IgG is a monomer, IgM is a pentamer, IgA is a dimer or sometimes a monomer, and the other two are monomers. So it's mainly just IgM, remember, is a pentamer. And that's kind of it, really. So in myeloma, what happens is a plasma cell gets kind of an abnormal mutation and starts proliferating. So it just becomes kind of a clone. And because of that, it means that you only have one type of plasma cells, and your plasma cells are what secrete antibodies. And so if you've only got one type of plasma cell, you're only going to be secreting one type of antibody. So it means you'll get what's called a monoclonal antibody, where there's just loads of one specific type. And usually it's IgG in about 60% of cases, but it can be IgA, or sometimes the plasma cells can just secrete light chains. So usually your plasma cells do secrete more light chains than heavy chains anyway, but you can get myelomas where they're just producing loads and loads of light chains. And those light chains will be, because it's a clone, they'll either be kind of kappa or lambda light chains. So it's just all of one type. And the problem with that is that you have all these extra antibodies in your blood, and that makes your blood a lot more viscous, and it also clogs up your kidneys. And also in your bone marrow, you get loads of these plasma cells. And because your bone marrow is just so full of this one cell, there's not much space for it to make other cells and function properly. So you won't be making as many of your other cells. So you won't be making so many red blood cells, which is why you're going to be anemic. You won't be making all your other white cells that are important in your immune system, so you'll get recurrent infections. You won't be making as many platelets, so you're going to be bleeding and bruising easily. And your plasma cells as well, they also secrete these kind of abnormal cytokines that messes up your bone metabolism. You don't really need to know much about that, but you just need to know kind of the symptoms. So I wouldn't worry too much about the pathophys. But this is the slide. I put stars on it especially because this is the one to remember. Most questions about myeloma that come up seem to just be about this mnemonic, which I'm sure you've all heard, which is CRAB, which stands for the main features of myeloma. So the first thing is hypercalcemia. And I try to remember kind of the features of hypercalcemia by the little rhyme that's bones, stones, thrones, abdominal moans, and psychiatric groans, other way around, abdominal groans, psychiatric moans, same thing. And that's kind of indicating that you're going to get bone pain, you can get renal stones, they have abdominal pain, they get quite constipated, and they can be a bit confused. And then, so that's the hypercalcemia part. Then you can get renal impairment, you get anemia, so you're going to have people who have all the signs of anemia, so fatigue, shortness of breath, they might look a bit pale. And then bone disease, so you get these lytic lesions, and you get kind of pathological fractures, and bone pain as well. And the most common presenting symptoms are actually bone pain and anemia. So it's actually really common to send off myeloma screens, because obviously loads of people present with kind of back pain and anemic. So it's, yeah, that's the most common presenting symptom, and they're quite common symptoms generally. So myeloma screens are quite frequently done. Some of the other features that aren't in the mnemonic are recurrent infections. So that's again because you're not making all of your other kinds of immune cells. Weight loss, loss of appetite, and generalized weakness, which are all just kind of general malignancy signs. So in terms of the renal impairment, what causes that is that you've got all these light chains floating around in your blood, and they can kind of clump together in your kidneys to form these casts that block up the tubules. You can also get something called amyloidosis, which is where the light chains all kind of join together into these sheets, which are called amyloid, and that can clog up your kidneys. And just being hypercalcemic as well can mess up your kidneys. So next question, which of the following is a strong risk factor for myeloma? So being Caucasian, having a high alcohol intake, being male, smoking, or having a personal history of MGUS.
So we've got a couple E's coming through.
Mm-hmm.
No? Just wait a little bit more. We've only got 3 people answering so far, so
Ah, okay.
Got another E. A few more.
Okay.
Yeah, a couple more E's come through.
Okay, cool. So the answer is E. You're all right. So some of the risk factors. Having a personal history of MGUS is probably one of the most important. Being Afro-Caribbean, so not Caucasian. Age greater than 60. Males are slightly more affected than females, but it's not as strong as having a personal history of MGUS. Obesity and family history as well. I think one of the most confusing things was like MGUS. I think it took me a while to kind of understand what it is. The MGUS stands for monoclonal gammopathy of unknown significance, and it's a kind of pre-malignant stage of myeloma, and it's the kind of thing where almost all cases of myeloma will start off as MGUS, but just because you have MGUS, it doesn't mean you're going to get myeloma. So MGUS is actually really common. About 3% of the population over 50 have MGUS. And obviously not that many people have myeloma. So MGUS in itself isn't particularly concerning. You just have this kind of excess production of one type of antibody, but it's not causing you any problems. So you don't have the crowding out of your bone marrow with plasma cells. It's still less than 10%, and you're not having any organ damage. So that's what MGUS is. You have this stage kind of in between MGUS and myeloma as well, which is what's called smoldering myeloma, which I think sounds horrible, but it's actually better than having multiple myeloma. And in that you have this kind of high production of one type of antibody. You do have your bone marrow being crowded out by these plasma cells, but there is no organ damage. They're not complaining of any bone pain. Their kidneys are functioning fine. They're not anemic. But if you have smoldering myeloma, they need to keep a bit more of an eye on you because you're a lot more likely to then go on to develop myeloma. And then in myeloma, you've got this really high production of one antibody. Your bone marrow will have more than 10% of plasma cells, and you've also got the signs of organ damage. So you've got the renal failure and the bone pain and anemia and all of that. So that's the difference. I hope that helps. We're going to go on now to talk about some of the investigations that you do for myeloma. So these are some typical blood tests that you'll see in myeloma. Can anyone point out to me kind of some of the things that are abnormal or some of the things that would make you think that it is myeloma? And if anyone could tell me what the peripheral blood film on the right is showing, then I'll be very impressed.
You can just give them a couple of seconds to have a look, and then
I've been mean and haven't put in the normal values, but I feel like you should pick up some of them anyway.
So we've got someone saying anemia, AKI, hypocalcemia, and Rouleaux Formation.
Yeah, nice. I wasn't expecting anyone to get that.
There's also someone saying target cells. No, too.
Yeah, they are actually. That one. I don't know if you could see my mouse. That one looks like a target cell. Yeah. Yeah. I think you got most of them, didn't you? You said about did you say about the white blood cells being low? That's the only one.
They did not mention that actually. No, they just said anemia. There's high creatinine. It's one of them. High calcium.
Yeah. So you've got the anemia with the low HB. Platelets, in this case, that's actually a normal value for platelets, but sometimes it is low. The white blood cells are low because you've got that crowding out of your bone marrow and it's not making all your other cells properly. Sodium's fine, potassium's fine. Urea is raised because of the kidney damage, as with creatinine. ALP, does anyone know a bit about ALP and why that might be raised?
No one's written. Oh, indicative of bone damage.
Yeah, exactly. So ALP, although it comes up in your liver test, it's the one that I'm sure Ganesh mentioned earlier, isn't specific to the liver, and it can indicate bone damage, which is why in myeloma it's raised. And then you've got your corrected calcium, which is raised as well, so the hypercalcemia. And then I'm very impressed that you got Rouleaux Formation. And what that is, for people who don't know, it's when you can see the red blood cells here are all kind of clumped together in chains. So when you have 4 or more red blood cells that have clumped together in a chain, is what's called Rouleaux Formation. And that happens in multiple myeloma because you've got all of these extra light chains in the blood and extra antibodies in the blood, and it makes the blood a bit more sticky, and that's why they'll stick together. You'll see that on the blood film. So the other thing that you do to diagnose multiple myeloma is either serum or urine protein electrophoresis, and that's kind of a long word just for saying that you'll take the blood and look at what's in it, basically. So it separates all the proteins in the blood or the urine into groups depending on the size and the charge. And this kind of green spike at the end here is what's called the M spike, which is characteristic of multiple myeloma. And it basically just means that you're making one like monoclonal antibody, so one antibody in excess of all the others. And if you look here, this is kind of the normal spread of proteins in the blood, where you've got kind of a little bit of everything, whereas in multiple myeloma you've just got this one spike which represents this one antibody being made in excess of everything else. And the other thing they mention a lot in kind of exam questions and to be aware of is when you have light chains in the urine, they're called Bence-Jones proteins, and that's something you'll see in multiple myeloma. It's in about 2/3 of myeloma patients, so it's really common. More likely to be kappa than lambda, but can be either. And then this is a bone marrow biopsy, so that's another thing you'd want to do if you're suspecting myeloma. And you'd want to do kind of an aspiration and a biopsy at the same time. The aspiration will give you kind of just information on the number of cells, and the biopsy gives you a bit more structural information about where those cells actually are in the bone marrow. And the kind of cutoff for it being myeloma is 10%. So if you have more than 10% of plasma cells in the bone marrow, that's pathological. And if you look at these pictures at the top, this top one is a normal bone marrow, and you can see it's got kind of lots of different cells, like lots of different colours, lots of different kind of shapes and sizes. Whereas this one, you have loads of these dark blue cells, and these are the plasma cells. And if you look at them as well, you've got the nuclei all in kind of different places within the cell. They all look a bit funny, and that's what multiple myeloma looks like on a bone marrow. And this bottom bit is just about, you can kind of put stains on the films to show up what kind of light chain they're producing. And in this one, you've got kind of a mixture of lambda and kappa, whereas on the multiple myeloma one, it's just producing all of these kappa ones, which are blue. You don't need to know that, but it's just the principle of that in one, you're just making one type of light chain. And does anyone know what these are all the kind of bony findings in multiple myeloma? This picture on the left here of this skull, does anyone know what questions like to call that? It comes up on, maybe a bit early for PassMed, but it comes up on PassMed a lot when you get.
Someone's typed in pepper pot skull.
Ooh, I think it's not actually. Ooh, that is one though. It's not the one I had in mind, and that is definitely one. It could be. I've got a different name for it.
Someone wrote raindrop.
Yeah, perfect. I'll look up what pepper pot skull is in a minute. That does come up as well. I can't remember what if it's for this or something different. But yeah, raindrop skull. And it's when you have all these round lytic lesions on the skull. And you also get these lytic lesions in other areas. So you can see them here in the arm, particularly dangerous one in myeloma is when you get them in the vertebrae. And when you get these kind of compression fractures caused by these lytic lesions in the spine, you are at very high risk of getting spinal cord compression, which is obviously really dangerous and horrible. So that's something you worry about a lot in myeloma. And on this like neck of femur here as well, you get something called endosteal scalloping, which is where you can see these kind of little bumps in the neck of femur. And that's also caused by the lytic lesions in the femur. There are a couple of other investigations you might want to do. So you might want to look at just how many light chains there are in the blood. If someone's got pathological fractures, you're no doubt going to go on and do a CT or an MRI, but some kind of further imaging. You might want to do a renal biopsy a bit later down the line, and then some of the prognostic markers for myeloma are albumin and beta-2 microglobulin. So if you have a low albumin and a high beta-2 microglobulin, that's a really bad prognostic marker. You don't need to know that for GEP-1 though, so don't worry if you haven't heard about that. In terms of management of myeloma, it's still incurable, but the aims of management are kind of split into two parts. So the first thing is to induce remission, so to just try and stop the proliferation of these plasma cells. And that's done with chemotherapy or sometimes stem cell transplants, more commonly chemotherapy. And the second part of the management is just to control the symptoms. So to help with the bone symptoms, you can give bisphosphonates to strengthen the bone. You can give dialysis if they're in renal failure and they've got, really high potassium, or they're really acidotic, they're having issues because their kidneys aren't working, then they need to go on dialysis. You can give blood transfusions or EPO to help with the anemia. They need to be vaccinated because they're not making all of their other white cells that are going to help fight off infections. And also because the blood having all these extra antibodies in, it's very viscous. So you need to think about VTE prophylaxis as well. And on top of that, some of the medications that you give, like EPO, for example, and some of the chemotherapy agents actually make them more prone to clotting as well. So on top of already being prone to clotting, they are given more medications that make them prone. So it's just something you need to think about. That was everything I had to go through. Some other things that just to go through in your own time for this week is the anatomy of the vertebral column, intervertebral discs and spinal cord and nerve roots, and the lymphatic system as well. It's just something to know for this week. But does anyone have any questions?
Can't see any questions.
Cool.
I just looked this up. The pepper pot one is for hyperparathyroidism.
Yeah, that's the one.
There's a question here. Can you repeat control symptoms?
Control symptoms. As in, do you want me to share my slides?
How to control symptoms, I'm guessing.
Okay. Let me put my slide up again. How do I get off? Let me share my screen quickly. I wouldn't worry, just to say, I wouldn't worry too much about the management for GEP-1. I think they're more, the main thing questions ask about, to be honest, is just identifying those myeloma. Quite a common question will just be to give you kind of the blood set that I've mentioned, or just mention, and for someone over 60 with bone pain and anemia and what investigation might you want to do. It's just to consider it as a differential. But in terms of controlling the symptoms, so bisphosphonates are going to help strengthen the bones, so to try and prevent the pathological fractures. Dialysis, because they might be in renal failure. Blood transfusions or EPO to help with the anemia. Vaccinations, because they're not going to have many of their other white blood cells that would usually fight off infection. And VTE prophylaxis, because their blood's a bit more viscous and they're prone to clots. I hope that answers your question.
Hi guys, I'm Ellie, and today I'm going to be covering the last part of this module, so it will be TB and also breast cancer. So TB, this is an infection caused by Mycobacterium tuberculosis, and it most commonly involves the lungs, and when the lungs are infected, this is when TB is transmissible. But it can also affect many other organs in the body, so pretty much everywhere in your body, and you get some really odd, unusual symptoms that can be caused by TB throughout the body. Risk factors for TB, there's certain countries and areas that are higher risk, people that are immune suppressed either by disease such as HIV or if they're on chemo or other immune suppressants. And then also there is a link to poor socioeconomic status, particularly being homeless or living in sort of overcrowded spaces. And then I've added this quote. This was a comedian about, I can't remember how many years ago, that made this sort of slightly poor taste joke, I reckon, about TB. But his point was really that TB is sort of seen as this Victorian disease that we don't really deal with anymore, when in fact it's actually a lot more common than we would realise, particularly in certain areas of London. So this is just a map from a few years ago in 2018, and you can see the boroughs highlighted in red are sort of there's 40 plus cases per 100,000 of people with TB. And in 2010, the Lancet published an article saying that we actually had some of the highest rates in Europe. And this has got slightly better, particularly in the last few years. And researchers reckon it's probably because the last few years we've all been isolating and wearing masks, and that's helped a little bit. But the UK government has launched a 5-year action plan to reduce TB from 2021. So it's a sign that it is still a problem and it is still happening. And it's certainly something that you may see on some of your placements down in London as well. So the symptoms of TB, cough is the main one, hemoptysis. People also describe weight loss and night sweats. And when you ask patients about sweating at night, be quite specific and say, if it's not just a little bit sweaty, it's so sweaty that their bed sheets are soaked and their clothes are soaked. People can get fevers and just generally feel unwell, so like loss of appetite, feeling tired. And then we won't go into loads of detail about extrapulmonary TB. I have got some slides and a little bit about that, but it's quite non-specific symptoms in other areas of the body. So pain, swollen lymph nodes, or if it's within the brain, you can get all sorts of strange psychiatric symptoms from it as well. So how is it transmitted? So somebody infected with pulmonary TB is going around and they're coughing. This is inhaled by somebody else, and the TB makes its way down into the air spaces in the lungs. And then here you've got your alveolus, so your TB bacteria enter the alveoli, and then you've got your alveolar macrophages, which engulf the TB. So they do their job and they try to get rid of it. However, TB are really good at surviving attacks from the immune system. So what actually happens is that they don't get destroyed by the macrophage. They kind of just stay alive and stay dormant in there. And the immune system deals with this by sort of building this area around the bacteria called a caseating granuloma. So the structure of this is, as it shows here, you've got a ring of macrophages surrounding the TB in the middle. And then you've also got T cells around the outside. And then you get fibroblasts eventually sort of forming a ring around the whole thing. And you get this central area of necrosis. That's why we call it a caseating granuloma. And it's a very classic sign of TB infection. So you might hear about active and latent disease. So around 5% of people will develop active disease when they first catch TB. And this is usually very, very severe. It can spread throughout the whole of both lung fields. You might hear about the term miliary TB, and that is on an X-ray. You can just see TB everywhere, or loads of tiny little dots that look apparently like millet seeds. However, in over 95% of people, the bacteria are actually contained in the granuloma, and the disease then enters its latent phase, so the person won't show any symptoms at this point. The formulation of granuloma is a type 4 hypersensitivity reaction, and we'll go through the types of hypersensitivity in a little bit as well. And then a Gone complex is the granuloma plus mediastinal lymph nodes being enlarged on the same side. And over time, this Gone complex, the lymph nodes and the granuloma will calcify, and then this then is known as a Ranke complex. And then the TB sort of stays there dormant. It can stay for many, many years, but when that person becomes sort of sick or weak, particularly things like starting chemotherapy, the TB can become reactivated and they can develop active disease. And then here are the 4 types of hypersensitivity. So type 1, IgE mediated, that's things like anaphylaxis, for example. So you can see here the allergen is binding to receptors on the mast cell, and then the mast cell degranulates and releases all these inflammatory mediators, which cause the symptoms then of an allergic reaction. Type 2 is activation of the complement system. So you've got surface antigens and immune complexes involved in this one. And then the slightly different between this is type 3. So in this one, rather than it being sort of single surface antigens, you've got this free floating immune complex. So a collection of antibodies in like a ring sort of formation. And then type 4, such as a granuloma, is a delayed hypersensitivity reaction. So this involves the maturation of T cells becoming sensitized to a particular antigen. And then when that antigen re-enters the body, they reactivate sort of to kill that bacteria. And then I said sort of I'd really just briefly go over this. So TB can affect so many different areas in the body. Lymph nodes are very commonly involved, and it's often a sign that you'll see on a chest X-ray is sort of mediastinal lymph nodes being enlarged. But you can also get cervical or supraclavicular nodes that are enlarged as well. GI symptoms, people can present quite non-specifically with abdo pain, weight loss, anemia, and as you can imagine, a lot of these patients will be investigated for lots of other things first, and people often won't think about TB until later on, although over half of these people will have TB, sort of evidence of a Gone complex or a Ranke complex on their X-ray. You can get TB in the bones, so the spine is commonly involved, and this is called Pott's disease, and can present with sudden vertebral collapse and fractures. And you can very rarely get arthritis associated with TB, and that often happens in young children. Miliary TB we've briefly mentioned, so this is where a person sort of catches TB in the first instance and it's an active infection. You get spread throughout the whole lung field, but also systemic symptoms as well, and that really is quite severe. CNS TB, again, quite rare. It's often as a consequence of untreated pulmonary TB. I saw quite a few cases in Croydon when I did my placement where there were patients who had sort of, they'd sort of not gone to seek any help for their TB symptoms, and then it had unfortunately become the CNS TB, presenting with psychosis and reduced consciousness and things like that. And then also you can get skin lesions and rashes and pericardial TB, which is really rare, but it can result in pericarditis. So how do we investigate and diagnose? So the first investigation of choice is a chest X-ray, and you can see here on the right that arrow there pointing to the right upper lung. You can see those cavitating lesions in there. There's also quite hyperinflated lungs there anyway. And then you also want to do a sputum smear on patients. So this really important feature to remember for your exams. It's 3 separate early morning samples, and you're testing them for acid-fast bacilli. So you can see on the bottom right-hand picture there, Zeal-Nielsen stain is a particular type of stain which highlights the mycobacterium, and they show up this kind of bright red colour, but it needs to be these 3 separate samples to test accurately. Sometimes now they use this NAT test to sort of genotype the bacteria, particularly to see whether they're resistant to treatment. And then you can also do sputum culture. So this takes quite a long time, and TB is notoriously hard to grow in a lab as well. It often doesn't grow correctly, but you can sometimes use this to identify what the bacteria are sensitive to. And then just general other tests. So you can do a full blood count, which can show high number of white blood cells. It can show anemia. And if it's a systemic disseminated infection, you can get pancytopenia as well, and your patient will be really unwell at that point. If there's people who've been exposed to TB, but they haven't got any symptoms, you can do what's called the MAN2 test. So that is injection of an isolated sort of TB protein into the skin, and you leave it for a few days, and then you measure the skin reaction. So if it's over 5 millimeters of this redness and swelling, and that's a positive indicator that that person has a latent TB infection. And then how do we manage TB? So again, this will come up a lot in your exams. So it's RIPE, which is rifampicin, isoniazid, pyrazinamide, and ethambutol for 2 months. And then RI, so just rifampicin and isoniazid for a further 4 months. And the side effects of these drugs as well are quite specific. So rifampicin can cause orange secretion, so orange tears, orange urine, orange sweat. So it's important to let your patients know that this might happen. It is toxic to the liver, as are most of the TB treatments. So you have to just monitor the patient's Lfts throughout their treatment. Isoniazid, the main side effect to remember is peripheral neuropathy. So it's given with pyridoxine as a prophylaxis to try and stop this from happening, particularly in high-risk patients. So people with things like type 2 diabetes who are already at risk of peripheral neuropathy. Pyrazinamide can cause joint pain, and it's also toxic to the liver. And ethambutol can cause problems with the eyes, so things like decreased acuity or even colour blindness. So at the start of treatment, we test people's eyes and obviously just monitor them for any changes while they're taking that treatment. For the first 2 weeks, they're still considered highly contagious, so the person would need to isolate, and they need to have 2 negative sputum cultures before they're truly considered to be non-infective. And there is this directly observed therapy. So for people who we don't think, will take the treatment, you can sort of make them come in and sort of take the medication in front of a clinician. And then if it's a contact, somebody who's had a positive MAN2 test after being exposed, for example, we give them just isoniazid and rifampicin, or there's another drug similar to rifampicin called rifapentin. And then contact tracing. So TB is still a notifiable disease, and if a person's diagnosed, PHE will trace people from the last 2 years and offer them treatment if they're thought to be high risk. It's actually quite hard to catch TB, so it wouldn't just be, I was on the same bus as this person. It would be people like housemates and family members and things like that. And then once the treatment's completed, people don't usually need follow-up unless they've had a really resistant disease or they've got evidence of lasting lung damage. And things that can happen include bronchiectasis, so scarring of the lungs. You can get right middle lobe syndrome, which is collapse of the right middle lobe due to mediastinal lymphadenopathy. And you can also just get, extensive destruction of your lungs, particularly if the TB was diagnosed or treated late. Okay, so that's it for TB. Does anyone have any questions on any of that?
There was one a bit earlier when you were on the slide about investigations. I think it was someone asking if the investigations were in order.
Okay, yeah, sure. Let me just, go back. Yeah, so I think if, just imagine that you're meeting someone in clinic and they're coming in with this cough. And at the moment we have our suspicions, but we've got no idea what they've actually come in with. So chest x-ray would definitely be your first investigation. Pretty much anyone presenting with a sort of long-term chronic cough, that's one of the first things that you'd want to do. If you're then sort of highly suspecting that they've got TB, they've got the cough, they've got positive x-ray, and they've got these other symptoms like fever, night sweats, then we would definitely want to do the sputum smear. And then once that's done and identified, then we'd look at culture. So I would say, yeah, so x-ray, then a sputum smear, or a NAT, and then a sputum culture. And then FBC would probably just come at the beginning when you're first seeing them and doing like your routine wide net of tests. Yeah, and then obviously after that, report to PHE and look for exposed contacts. Plugging in my laptop, just 1 second.
There's a couple more questions as well when you're ready.
Yeah, I'm ready.
Just one person asking, how do you know it's latent?
Yeah, good question. So if they've got, so firstly, they'll have no symptoms of TB. The point about latent TB is that they don't know they've got an infection. They've got no cough or fevers or night sweats. It's just that they've incidentally been found. So some people with latent TB just don't get picked up unless they're notified that they're at risk and they go to get tested. It might just be wandering around with it and never know until it becomes reactivated. Yeah, so unless they've had a positive MAN2 or they've been told that they're at risk, then they might not necessarily know.
Cool. And then there's one other comment/question saying that they thought TB was quite easy to catch.
Okay, yeah. So I was always told at med school that it's easy to catch if you're in contact with that person for a while. So I guess you'd use something like COVID, for example. COVID has sort of been found that you have to have very little time sort of in the vicinity of someone with COVID to catch COVID. For TB, they reckon it's about 15 minutes of close contact with a person to catch it. And that sort of involves being in a closed space less than 2 meters apart. So yeah, so it's not things like public transport or things that are a risk there, but it is things like housemates and stuff like that.
That's so interesting. I didn't know that.
Mm.
Someone said, I think they said 2 or 3 inhaled droplets were enough to start an infection.
2 or 3. Okay.
Yeah,
It's interesting. I don't have a sort of a textbook definition for that stat, unfortunately. It was just something that when I was at Croydon and on respiratory, the consultants there were saying it's quite hard to catch, and it's this 15 minutes of contact. But where they got that from, I'm not too sure.
I mean, we had a lady on our ward who had TB, and we didn't realise for quite a long time. And as far as I know, no one got TB. But it's my only anecdotal evidence.
Yeah.
Other than that, no questions though, just people saying thank you.
Lovely, thank you guys. So I'll move on now. So this is the final topic of the night. So we're going to talk about breast cancer and just briefly common breast conditions. So things that you might come across so early on in med school are fibrocystic change. So this is when people are sort of going through their menstrual cycle and you get changes of the breast. So women often say, on my breasts feel quite lumpy at certain times of the month, but then that sort of changes with their, where they are in their cycle. You can get fibroadenomas and benign cysts. So these are sort of your differential for lumps in the breast that are not malignant. So obviously a lot more common in younger people. Cysts particularly have a very typical appearance on imaging. So it's a fluid-filled sac. It's often very mobile on examination. Mastitis and breast abscesses occur in breastfeeding women. So infection of the ducts, which can become blocked, and it's sort of really painful. This can build up into abscesses, which sometimes need draining, and that's treated with antibiotics. But the main topic that we're going to talk about tonight is malignancy. So I'll move on to that. So breast cancer is obviously a malignant tumour originating within the breast. It's relatively common, so it affects nearly 1 in 8 women in the UK. It can also happen in men as well. It's very, very rare. I think it's about 200, 250 cases in the UK a year. In women particularly, there is a hormonal or a genetic link to their breast cancer very often. So BRCA1 and 2 genes, which I'll come on to in a little while. Uninterrupted estrogen exposure is one of the biggest risk factors. So think about things that would increase your exposure to estrogen. So having your period early on, having your menopause late, never having children, having your first pregnancy at a later age, or taking the combined oral contraceptive pill. And then, as with many other medical conditions, you're also more at risk if you've had breast cancer in the past of it recurring. So there's different sorts of breast cancer. So there is non-invasive ductal carcinoma in situ. And this is not by definition a cancer because, as we'll come on to shortly, it cannot metastasize and it doesn't invade into the basement membrane. However, it is treated as a cancer because if it's left alone, it will go on to sort of invade and become worse. And you can see on the diagram, it's confined to the ducts. It doesn't invade into the surrounding tissue. Invasive ductal carcinoma is the most common type, so over 70% of cases, and it's a tumour that starts within the ducts and spreads into the surrounding tissue. You can also get invasive lobular carcinoma, which starts in the lobules, and then you'll also hear about these tumour markers as well, and sort of their effect on treatment. So estrogen receptor positivity, it's tumours that express estrogen receptors, so they grow in response to estrogen, and that drives their growth. And 60 to 70% of tumours express these receptors, but that also means that we can target them with specific chemotherapy drugs that also attack these receptors and help to shrink the cancer. There's also HER2 positive. So again, this is a different sort of receptor that a tumour might express. This is associated with more aggressive disease and therefore poorer prognosis, because HER2, the presence of HER2 promotes the growth of cancer cells. And then the worst type of breast cancer to have is what we call triple negative. So if they haven't got HER receptors, estrogen receptors, or progesterone receptors, and I know that sounds a little bit, odd because we've just said that having them is sort of better prognosis, but actually, if you've got all 3 of them negative, this has got the poorest prognosis because there's very little for chemotherapy drugs to specifically target. The chemotherapy drugs often work in tandem with those receptors. And then what sort of symptoms are suggestive of breast cancer? I found this nice little summary online. So if you feel a thickened area of skin on your breast, that could be a sign. If you see dimpling of the skin, if there's sort of crusting or kind of eczema type skin changes around the nipple, that can be a sign of something called Paget disease, which is a breast cancer that's grown out of the ducts and out of the front of the nipple, and sort of is now affecting the areola as well. Redness or hotness, it can suggest infection, but it can also be sort of a rarer type of inflammatory breast cancer, which is really aggressive. Unilateral nipple discharge, particularly if it's bloody. Skin sores or changes to the skin, a visible lump, a growing sort of distended vein. So this can be a sign that there's a tumour sort of blocking the blood supply that's causing distension of the vessels. Sunken nipples, change in shape, what we call orange peel skin or peau d'orange. So it sounds really odd until you see it, but literally where the breast skin is sort of becoming tense because there's tumour in there, you can see all the pores sort of standing out, and it's got this orangey appearance. So yeah, particularly concerning symptoms are tethering the skin, because that's a sign that there might be a tumour there that's sort of pulling in other surrounding structures. Peau d'orange, unilateral discharge, particularly if it's blood-stained, and this scaling that can suggest Paget's disease are particularly concerning and sort of more unique to breast cancer, as opposed to, you know, a lump needs investigating, but it can be down to other things, such as fibroadenomas and cysts. So any breast lump at all in a woman of any age needs to be assessed by somebody, because it would be easy to miss breast cancer in younger women if we just to investigate older ladies. So we send people for triple assessment. So this includes a physical examination of the breast. We take a sample of the lump for cell pathology and imaging as well. And in women sort of over 40 years of age, then we use mammogram, which is an X-ray. And under 40, we use ultrasound to assess lumps. And then women aged 50 to 70 are offered mammograms routinely every 3 years. And the imaging might start earlier if women are known to have Bracha mutations. Yeah, so it's just gone over. It's a physical exam of the breast, which you'll learn to do in your OSCEs. Cell pathology. There's 2 types of cell pathology we can do. So we can do a fine needle aspirate, which is literally sticking a needle into the lump, taking some cells, but it isn't always accurate. As you can imagine, it's quite hard to stick a tiny needle in and get where you want to be with an accurate sample. But if you do get cells, it's a very good test at identifying malignancy. But what's preferred is a core biopsy. So local anaesthetic is applied to the breast, and then it's like a larger needle is stuck in, and it takes a central punch of tissue out. So it's a larger sample, but can lead to inadequate sampling, and it's sort of, there's pros and cons of doing that, but basically local anaesthetic, taking the sample, and it's done via ultrasound guidance.
We just got a question here, if you can repeat, I'm guessing about the imaging.
Yeah, not a problem. So different sort of imaging that we might do for breast lumps. So if it's a woman under 40 years old, and we tend to do an ultrasound, and the reason for this is 2 reasons. One, because the tissue in women under 40 tends to be more fatty and sort of dense, and it can be quite hard on a mammogram to sort of see individual tumours, but also sort of radiation risk. Sort of frequently X-raying women's breasts under 40 is also a cancer risk in itself. So yeah, we prefer an ultrasound for under 40s. And then over 40s, the breast is less dense, so it's easier to see sort of individual sort of lesions in there. If you look up, if you're interested to look up online, there's sort of images of a mammogram in a younger person compared to an older person. They have compared 2 images, and you'll see that in a younger person, the whole breast pretty much lights up on the X-ray. You can't really see individual tumours, whereas in an older person, you can see much more clearly the individual areas. Does that make sense?
Yeah, got a thank you.
Oh, great. Okay, so just briefly, we're going to go over some of the cell pathology behind all this. So here you've got your cell cycle. So you've got, well, depending where you want to start. So starting with mitosis and division of the cell, then you've got G1, which involves duplicating cellular contents, excluding the chromosomes. The S phase, where each of the 46 chromosomes is duplicated by the cell. The cell then double checks all these and makes its repairs as necessary, and then the cell divides again. So this is just going round and round in your body. You've got G0 after mitosis, where cells sort of go into this sort of dormant stage and the cell cycle arrests. And then how does that affect cancer? So you've got your cell cycle here, a slightly different diagram, except this time you can see your checkpoints on here. So your cell cycle here, so your checkpoints, particularly the one at the end of G1, P53, that is a really important tumor suppressor gene. And that stops damaged cells at that point from continuing to go round the cycle. If they're sort of defective at that point, P53 means that they just get, you know, they stop growing, stop dividing, and they exit the cell cycle and they die off. However, if you lose your P53, then you're more at risk for abnormal cells carrying on around the cycle and sort of growing and dividing when they shouldn't have. And oncogenes, so RAS and MIC particularly in that triangle, they are genes that drive cell division forward, even if they're defective. So it's a bit like putting your foot on an accelerator and not using the brake. The cells are just going round and round, and that's where you get, you know, more abnormal cells with these different mutations that leads to cancer. And here is something called the two-hit hypothesis. So the top line is a sporadic cancer. So you've got two copies of a gene at birth, for example, and then one becomes mutated and defective, but you've still got one sort of gene there that's not affected. That then might be affected sort of later in life, but you've kind of got two chances of the cell sort of staying normal, if you like. Whereas if, for example, you've got something like a Bracha mutation along the bottom line, you've got one gene that is affected at birth. So it only takes one hit to lead to a cancer. It's almost like you've got two chances on the top line of things going wrong. Whereas if you've got this predisposition, you've got one faulty gene at birth, it only takes the one hit to lead to a cancer. So Bracha mutations, which is exactly that, they've got a 50% chance of inheritance if one parent carries the mutation, and it can be carried by men or women. 55 to 72% of BRCA1 carriers and 45 to 69 will develop breast cancer by the time they're 80. This is compared to about 13% of the general population. And it's also a higher risk for ovarian cancer as well. You can be tested for BRCA. So particularly if you meet a patient who there's a lot of relatives in her family, lots of women who've got breast or ovarian cancers, this is when you might suspect this. And things that you can do, so you can screen from an earlier age. People sometimes as well go for prophylactic surgery to remove their breasts or their ovaries if they're really, really concerned that this is going to happen. Okay, and then here's the staging of breast cancer. So stage 1, the tumour is confined to the breast and it's still quite mobile. Stage 2, the growth is still confined to the breast and it's mobile, but there are lymph nodes in the axilla in the same side. Stage 3, the tumour becomes fixed to the muscle wall. So when you examine, you physically can't move the tumour around. There's also sometimes fixed lymph nodes on the same side, and it's more likely to have skin involvement as well. And then by stage 4, the tumour is completely fixed to the chest wall, and they may also have distant metastasis. So how do we manage breast cancer? So stage 1 to 2, where, as we've just said, the tumour is fairly mobile, sometimes we can just remove the tumour with wide local excision. Or if it is quite large, we may opt to do a mastectomy. And we can also sample sort of any nodes within the axilla as well. So one important thing to learn about is sentinel node biopsy. So when we remove a tumour, we often do, it's either by injecting dye or by injecting sort of radioactive material into the tumour site. And then we call the patient back in a few days and we sort of scan their breast with a Geiger counter to find out which lymph nodes have picked up the most of the radioactive material. And then we can remove that node that's called the sentinel node and dissect that in the lab. And if the sentinel node has got cancer cells within it, then you might opt to do an axillary node clearance, because if it's spread to the sort of first lymph node from the tumour, there's a higher chance that it's spread to other lymph nodes going up into the axilla. If you do remove these lymph nodes, it can cause lymphedema in that arm. And then also we've got endocrine agents. So as we mentioned earlier, these estrogen and progesterone receptors sort of respond to certain drugs. Tamoxifen is a really commonly used drug for estrogen receptor positive tumours. If we have removed the cancer and it's was sort of very large or highly invasive, we may also opt to do some radiotherapy, which reduces the risk of recurrence, or some neoadjuvant chemo. And this can also, if you've got a large tumour, if you can shrink it a little bit before surgery with chemo, then this might mean, you know, more of the breast is saved, particularly in women with smaller breasts. And then not straight away, but a lot later on, we can think about reconstructing the breast, often taken with sort of muscle flaps from different areas of the body. If the person's not a smoker, that is, because if they are, there's a higher risk of that sort of failure of that reconstruction. Or you can use artificial implants, you can tattoo on nipples and things like that. And then in people with more advanced disease, so particularly spread to other parts of the body, median survival is now over 2 years, and this is quite greatly improved on what it was 5-10 years ago. So firstly, you want to stage people and do investigations, so particularly bone scans, ultrasound of the liver, you might do a CT or an MRI, and some regular blood tests as well. If there's bony lesions that are causing pain, you can use radiotherapy directed at them. And if there's sort of small brain mets, we can do targeted radiotherapy, what's called cyberknife, to try and get rid of those. There's obviously a lot of multidisciplinary support as well, discussion at specialist meetings, having access to specialist nurses, and then patients are followed up for 5 years post-treatment. And that's the end of my slides. Does anyone have any more questions?
There was one from earlier about what's LOH. I think it was on your slide about the 2 hit.
Oh yeah.
Around then.
Okay. Ah, sorry. LOH. Do you know what? I took this diagram off an article and I can't remember what that stands for. I think it's loss of heterozygous. I think that's what it meant to, what that means is basically when you've got two normal chromosomes, and then you lose one of them, you're left with just one homozygous chromosome, and then after that it's more likely to become cancer. I wouldn't worry about that as a term, it was just one that was on this diagram.
Someone in the chat's backed you up as well, said the same thing.
Yeah, cool. Thank you.
There are no other questions yet.
No worries.
Do you mind popping to the end of your slides, Ellie? Because I think we've got the QR code just for the feedback.
Yeah, absolutely.
And just to mention that there's a session tomorrow as well, which Ash is going to be doing, and Emily as well, going through lots of SPAs, which should be very helpful for your exams. Yeah.
Thank you. So please do fill out the feedback form, guys. That's really helpful for us. And if you fill out the feedback form, we can send you copies of our slides as well. So you can have those for your own learning.